Hi everyone and welcome. I'm Andrew. I'm one of the physician assistants here at the OSNC and Tri-City Spine team. And if you're watching this video, it's because you've been recommended for spine surgery. And that is a daunting and scary thing to hear. But in this video, we will go over what to expect before, during, and after surgery. And hopefully it will leave you feeling more prepared and more confident. Now first, let's go over why spine surgery is necessary in the first place. Now, surgery is always the last resort, and generally speaking, the best surgeon is the one who never has to cut at all. But sometimes it is simply unavoidable. Now, surgery is necessary when there is nerve pressure that has or will cause nerve damage, and every other conservative treatment will not work or will not fix the problem. The medical term for nerve root pressure is called spinal stenosis. And unfortunately, the natural progression of spinal stenosis is that it does not get better with time, and in fact, slowly gets worse over time. If gone unchecked or untreated, eventually the stenosis can cause permanent nerve damage. So the reason for spine surgery is to decompress the nerve and stop the progression of nerve damage, and eventually give the nerve a chance to heal. Now, what are some of the signs of spinal stenosis? Patients with stenosis will complain, of course, of neck or lower back pain, depending on where the pinch is. But patients can also say that they feel electrical shocks going down the legs, going down the arms. They'll say there's a sensation of water going down the legs, but nothing is there, or a feeling of heaviness, or just a dull discomfort. One of the telltale signs of spinal stenosis is the inability to walk distance. Patients will tell me, Andrew, a year ago I could walk a mile, no problem. But half a year ago, I could only walk half a mile, and now I can barely make it to my mailbox before I have to stop and rest. This is a classic sign or classic story of worsening spinal stenosis. Eventually, we start to see leg and arm weakness, and actually leg buckling and balance issues. When it's truly severe, and it actually is an emergency, we will lose control of our bowel and bladder. And if this happens to you, you need to call 911 and go to the emergency room for emergency spine surgery. Now, until that happens, we can prepare, and that is what your surgeon is doing. The reason he has recommended surgery is to avoid a situation just like that. As I said before, surgery is always the last resort. So what are some treatments we can do to prevent surgery in the first place? One of the more conservative and often more effective treatments is physical therapy, though if you're watching this video, you've probably gone through multiple courses and it's just not working. Oral medications such as Tylenol, Flexeril, gabapentin, Norco, or other narcotics can help dull the pain, though often it's just not enough. We also rely quite heavily on epidural steroid injections, which can give significant relief for weeks, months, and even sometimes years. But sometimes that's just not enough as well. In very rare cases, your doctor might recommend a spinal cord stimulator or a radiofrequency ablation where we burn the sensory nerves. Now rest assured that your doctor is well aware of these and countless other more conservative treatment options. If you've been recommended for surgery, it's because your doctor has evidence that these treatments likely will not work, and the risk for continued nerve damage is too high. In this case, surgery is both the last and best option. So let's talk about what happens from the time you decide to have surgery to the day you actually have surgery. Prior to surgery, we want you feeling 100% physically, mentally, emotionally, and spiritually. And preparing for surgery is probably easier than you would expect. You will be given either a neck or a low back brace depending on where you're having the surgery, and you'll use this following surgery at home. It's okay to sleep on your back or on your side with a pillow between your legs, but do not sleep on your stomach. If you have a 2-story house and you're able to make sleeping arrangements on the first floor, go ahead and do so. But if you have stairs that are unavoidable, we expect that you will be able to go upstairs, but just use them as little as possible. It's a good idea to clear yourself out about a day or two prior to surgery using a mild laxative such as Miralax. Of course, no eating and no drinking the night before your surgery. If you take a blood thinner or on an anti-inflammatory on a daily basis, you'll need to talk with your doctor about when it's time to stop these medications. Generally speaking, we want you to be off blood thinners and anti-inflammatories between 5 and 7 days prior to surgery. But again, this is something you need to specify with your doctor. On the day of surgery, you will present to the main hospital entrance, and if you're having Tri-City surgery, then simply turn to the right and go down the hall a few steps to registration. Arrive roughly 2 hours before your surgery time so that the intake nurses don't have to rush. Things to bring to the hospital are your ID, your cell phone, and bring your cervical collar or low back brace, and maybe one set of fresh clothes. If you take medication on a daily basis, you do not need to bring these medications to the hospital, as the hospital will give them to you when you are there. Likely, you will have many concerns that are particular to your situation, so please be sure to bring them up with your doctor. Between 1 and 2 weeks prior to your surgery, the hospital will call you to set up your pre-op appointment. At this appointment, they'll go over your medical history, do an EKG, chest x-ray, and at this point, they're doing COVID tests as well. Now, these tests are important to ensure that you are healthy enough to undergo surgery in the first place, and it's done close to the surgery date so that there are as few changes as possible. If you're taking narcotics or if you drink alcohol, especially daily, please be honest about how much you take, because that will help us get ahead of your pain after surgery. Now, if we don't know the information, it will be difficult for us to get ahead of your pain. The surgeon may also want you to see a specialist before surgery, such as a cardiologist or an ear, nose, and throat doctor. But if this was not specified in the office visit, they may not want you to see one. But everybody will get a pre-op appointment. Now, let's talk about what happens on surgery day. During surgery, the nerves will be decompressed by removing anything and everything that is putting pressure on them. This could be disc material, bone spurs, arthritic changes, anything. When the pressure is released, it's actually quite amazing because you can physically see the spinal cord go from this size to about that size. It's quite amazing. Now, because bone and disc material has been removed, the spine is now unstable and needs to be stabilized. This is where the fusion comes into play. Your doctor will also use a synthetic bone graft material made in a lab, which will slowly harden and make the fusion more solid over time. The days of getting bone graft material from your hip are over. It takes about a full year for the bone graft material to fully harden. Now, in the operating room, there's a special nurse who connects leads all over your body, and these leads can measure the function of your spinal cord. When the nerves are decompressed, we can see that the waveform of the spinal cord comes back all of a sudden to normal. This is how we know, or this is how your surgeon knows, that the surgery was a success. And with this technology, we can do the least amount of surgery to completely 100% resolve your issues. If you are having a posterior fusion in particular, your surgeon will likely use the Mazor robot to assist. It's very important to understand that even though we're using a robot, the surgeon himself is the one doing the surgery. However, the robot ensures 99.6% accuracy in the placement of the screws and the hardware, and this has greatly improved recovery times, and it's dramatically decreased the rate of redo surgeries. Prior to surgery, you will have to undergo a specialized CT scan, and the robot takes the information from this scan and uses it to make a map of your spine. Using this map, the doctor can actually plan ahead the size, pitch, depth of screws, and of course the angle of the screws as well. And then the robot during surgery helps assist guide the screw placement. Now, here's a really good model of a lumbar fusion. For orientation purposes, this is the sacrum and the patient's legs would be going this way. And this, of course, is the lumbar and thoracic vertebra, and the patient's thorax and head would be going that way. In this model, the patient is laying on their stomach. Now, as you can see, these are the actual screws that we use during surgery, and they're made out of titanium. The body absolutely loves titanium, and you can see they're on both sides there. They go into the strongest part of the bone called the pedicle. Now, on the side here, you can see these white foam parts, they represent discs, and in the middle here, the disc has been removed completely and been replaced with a PEEK cage, P-E-E-K. That's an acronym for the material that the PEEK cage is made out of. And you can't really see it on this model, but there are actually small screws in the cage itself going into the bone above and the bone below. So this is a really good example of a cervical fusion. As you can see, this is the front of the body here, and this would be the back of the neck. And in fact, these little spinous processes here, those are the bumps you can feel when you run your hand down the back of your neck. Now, of course, the very first thing that stands out is this titanium plate. And your doctor will screw in this titanium plate to make sure that none of these bones move. It's a little bit harder to see, but in between here, the discs between the bones have been removed completely and replaced with these PEEK cages. Now, your doctor will actually fill these cages with osteoagra, which is synthetic bone material that will harden slowly over time. One of the most important questions that patients have is, what can I expect for recovery? We can really separate recovery into three distinct sections. There's recovery in the hospital, then the first 3 to 6 weeks of recovery at home, and the next 6 months to a year of recovery at home again. Let's start by looking at recovery in the hospital. When you wake from anesthesia, you will be in the post-anesthesia care unit, also called the PACU. This is a quiet place where you get very close attention from the nurses while you brush off the cobwebs from anesthesia. Once the anesthesia has worn off, you will be transferred to your hospital room, which is where you will spend the majority of your hospital stay. Now, in order to leave the hospital, you have to meet certain criteria. 1, you cannot have a fever. 2, you must pass gas. 3, your pain must be controlled with oral medications, not IV medications. And 4, you must have normal blood work. If you're having neck surgery, plan to stay in the hospital 1 night, rarely 2 nights. If you're having low back surgery, plan to stay in the hospital 2, sometimes 3 nights. The hospital nurse will be responsible for administering your pain medication, and it is our goal to keep your pain level to a 3 while you're there. Most patients will also have a patient-controlled anesthesia button. This is a little device that you hold next to your hospital bed, and when you push the button, pain medication flows through the IV. In this way, you are more in control of your pain relief. Now, while you're in the hospital, your diet is greatly restricted as well. This is because the anesthesia not only puts your brain to sleep, but it also puts your GI tract to sleep. Now, usually, the GI tract is much slower to wake up compared to the brain. If you eat a large meal and you're not able to digest it, it will cause some major bloating and potential very serious GI problems. But once you start passing gas, that's when we know your GI system is starting to wake up and you can digest food again. That's when we start progressing you to more and more solid foods. The day of your surgery, your physical therapist will come to your room and help you start walking. Let me repeat that. We want you walking the day of your surgery with the help of your physical therapist. Most patients need to use a walker at first and then graduate to using a cane and then to nothing. So if you're not using a walker immediately after surgery, you're actually ahead of the curve. You will also have a case manager assigned to you, and this is somebody who coordinates anything you need when you transition from hospital to home. So for example, if you need a walker when you're at home, the case manager will help get it to you. A small minority of patients will need to stay at the hospital longer, typically 1 to 2 weeks, or will be discharged to a skilled nursing facility instead of home. This doesn't mean that anything went wrong. It just means that your doctor wants you to have some extra attention and recovery time before you go home. When you leave the hospital, you will be given 3 prescriptions: an antibiotic, a muscle relaxer, and a narcotic pain medication. Be sure to finish the antibiotic completely, but only use the muscle relaxer and narcotic as needed. When you are at home, you have 2 very important jobs. You need to walk daily, and you need to wear your brace. If you have a low back brace, you need to wear it when you're sitting, standing, or of course walking, and this will be true for about 2 months. If you're laying down or going to sleep, you do not need to be in the low back brace. Now the cervical collar, on the other hand, you will need to wear 24/7 for about 3 weeks. And yes, this includes when you're going to sleep as well. And I get this question all the time, Andrew, do I really have to wear the brace? Yes, it is absolutely critical to wear the braces. This is because the first 4 to 8 weeks of your recovery are critical to the overall recovery, and wearing the braces helps ensure that you recover correctly. Wearing the braces also signifies to society that you are injured, and people tend to give you more space when you're at the supermarket, for example. When walking, shorter walks multiple times a day is better than one big long walk, and I cannot emphasize enough how important it is to walk daily. To avoid infection, do not shower for at least 2 weeks following surgery. Instead, we ask you to sponge bathe to stay clean. Your doctor may order you a home health nurse or a home physical therapist to visit you a couple times per week in the early stages of your recovery. Their job is to help you move around the house and to ensure that you are recovering the way we expect you to. They are not there to help you do chores around the house. Likely, when you wake from surgery, you will have drains, either in your neck or in your lower back, and this is a normal part of surgery. You will likely go home with the drains as well. In the drains, you will need to remove the liquid or the output yourself, and please measure how much there is whenever you drain it. The general rule is the drains can be removed when you have less than 40 cc's of output over a 24-hour period. Now, when your surgeon says that you no longer need the drains, please do not attempt to remove them yourself. Either your home health nurse or somebody here at the office will remove them for you. It is very important to avoid all anti-inflammatories for at least 4 months following your surgery. Anti-inflammatories are ibuprofen, Aleve, Advil, Motrin, Bayer, and of course all steroids. This is because when you have the fusion, it uses inflammatory chemicals and signals to harden correctly. And if you take anti-inflammatories, it may not harden correctly, and this is a big problem. Because you cannot use anti-inflammatories, this is one of the main reasons why we rely so heavily on narcotics for pain relief. It is also important to know that it is not uncommon to develop new sensations in the legs or arms after surgery that were not there prior to surgery. This is because when the nerves are decompressed, they are still damaged and they are still recovering. As they get these new sensations, you will start to feel new sensations in your legs or arms, and it's important to know that this is normal, and in fact, it's a sign that the nerves are starting to heal. Whether you had neck or back surgery, your first post-op visit in the office with your surgeon again will be 3 weeks from the date of your surgery. At this visit, and actually every follow-up visit for the next year, we will take x-rays, look at the fusion, and assess how you are recovering. Typically, we want you to come in for x-rays at the 3-week mark following surgery, then 2 months, then 4 months, 7 months, and 1 year. Of course, if you have new symptoms, you can always come in earlier or at a different time. For neck patients or cervical spine patients, physical therapy typically starts 1 month following surgery. And for low back patients, physical therapy typically starts 2 months following surgery. Please do not try and strengthen or do any other exercises until physical therapy starts. And again, when you're at home, what we want you to do is walk, walk, walk. If you follow these guidelines, we are sure that you will recover well. Now, here are some common restrictions and milestones that we get asked a lot. You can be the passenger in a car immediately following surgery, but we don't want you to be the driver for at least 3 weeks. And in fact, it's actually illegal to drive to be the driver when you're wearing a cervical collar. Do not travel long distances for about 2 to 3 months following surgery. And when I say long distances, I mean anything in a plane or any driving over an hour. This is to avoid developing a blood clot, very important. And one of the most important questions I get is, when can I play golf again? Typically, we want you to play golf again at about the 8-month mark following surgery. Lastly, it takes about a year to a year and a half for full recovery. This is because nerves heal very slowly, and in fact they heal about 1 millimeter per day. So you can imagine you have one long nerve from your lower back all the way down into your big toe. That is a long way for it to recover, but it will. And over this year to a year and a half, you will feel stronger, your pain will improve, and you're going to get your life back. Realistically, our patients get better. And that's the whole point of surgery, is to get back to your life. So please, again, don't hesitate to call and to ask questions. The more comfortable you are, the better your surgery will be.